Hey guys, how are y'all doing? Last speaker of the day. Everybody need anything to drink? Any coffee? We got some purple chocolates over there if anybody needs to pick me up. So first of all, thank you guys for letting me be here today. This is my first Scleroderma Foundation activity. Matter of fact, I just started a new job over at Northwestern. Some of you guys have asked me about that. I just started about a month and a half ago over there. I've been over at Loyola for the last 7 or 8 years or so, and was recruited over to Northwestern recently. So I've been really happy to join this amazing team of people over here, some of which we'll hear from a little bit later. But today, I've gotten a lot of insight talking or listening to you guys talk and ask questions over the course of the day, and so we'll kind of work through the talk, but maybe I'll pause in some different areas and we can ad-lib a little bit. And obviously, speak up, raise your hand if you want, just shout out if you want. Any questions as it pertains to interstitial lung disease, and we're going to kind of do a little bit of a dive into clinical trials. One of the things that, we really like being able to do is trying to find new and better therapies for scleroderma, specifically scleroderma interstitial lung disease. And one of the ways that we do that is by asking you guys to volunteer to participate in clinical trials, and that can be a pretty scary thing. Maybe it's a big black box and you don't know much about it, and hopefully today you'll know a little bit more about it after our discussion. And I'll share with you a little bit about some of those clinical trials that have then led to breakthroughs and led to discoveries of medications that we will offer patients with scleroderma interstitial lung disease to try to slow down or halt the progression of what can be a very progressive and bad disease. So we'll work today by working through a few objectives first. So kind of first understanding big picture, how does scleroderma affect the lung? Then we'll kind of jump into that section where we'll talk about different types of clinical trials, how you might be able to participate, what would be expected of you, what you should expect of me as a leader in that clinical trial. And then we'll flip and talk about some of those breakthroughs that have happened over the years. So first off, I made this slide a little bit rushed, and just ignore the fact that this says tumor here. This is not what we're talking about. It is just supposed to be lungs. So what we'll talk about here is the anatomy of what lungs look like and what's affected in scleroderma interstitial lung disease, okay? So your lungs are these nice big pink fluffy sponges that kind of expand and contract with every breath you take with your diaphragm moving up and down. Those sponges are made up of all these tiny little beach balls or balloons that we call alveoli, these air sacs in that middle picture. You can see kind of it's an airway that goes down and just leads to all of this kind of like grape-like things on the end of a stalk. Those areas, magnified even more on the picture all the way on the right, is what an alveoli looks like, one of those air sacs. You can see the lung is actually mostly nothing, right? It's mostly air, which is great. That's exactly what it should be. When we take a deep breath in, those air sacs get bigger and they fill up. And in the walls of those air sacs, we see capillaries, or some of those small blood vessels that are really intimately involved with taking oxygen from the air we breathe in and getting rid of the carbon dioxide out of our blood, so we exhale that carbon dioxide. That's really what the lung does for us, okay, right? So when we talk about scleroderma interstitial lung disease, we're talking about a disruption of that. And really this is common to all different types of interstitial lung disease or pulmonary fibrosis. Some of these terms are synonyms and interchangeable with each other. So in this example, you can see the first picture over on the left is just those nice, healthy, fluffy lungs again. Our middle picture, you can see depicted is that interstitium, or the kind of that area right outside of our air sacs that is in between the blood vessels and the air sacs. And that interstitium, that oxygen, carbon dioxide going either way. The third picture over on the right is that when that interstitium becomes affected with scar tissue, excess fibrosis, that diffusion of gases can become a little bit more difficult. It's harder to get the oxygen in and sometimes harder to get the carbon dioxide out. This is really the main problem that we run into. And instead of being big, fluffy, pillowy type organs, the fibrosis and scar tissue turn these into kind of more smaller and harder and less movable, less mobile lungs. So when you take that deep breath in and your diaphragm goes down, those lungs don't expand quite the way that they used to in the setting of interstitial lung disease. What we'll talk about is, again, how we can prevent that from happening, how we can detect it happening early so that maybe we will be able to make a difference and start treatment sooner. We've seen a couple of these pictures today. This is maybe a little bit weird looking, but it's a CAT scan, just a CAT scan of the lungs, or a CT scan. At the very top of the picture is the chest. At the very bottom of the picture is the back. You can see the bony spine in the back. On the sides, or the sides of the body, and those big black things in the middle, those are the lungs. You can see air outside of the body is black. Air inside of the lungs are black, and so that's nice, healthy-looking lung tissue. Some of those little white splotches in the middle, those little lines, are blood vessels, and those are normal. So this is what a normal lung looks like, okay? You can say, like I said, the lungs are mostly air, so that air, that darkness is really what we're looking for. When we see scar tissue start to develop, that scar tissue becomes more white or light gray. I'll have a picture of it on here at the bottom. You can see the extra white stuff around the edge of the CAT scan here, around the edge of those lungs. That's what interstitial lung disease, or ILD, looks like in all kinds of fibrosis. So what about scleroderma in specific? So scleroderma is probably the most common of the autoimmune conditions that leads to lung scarring, okay? About somewhere between 40 and a much higher number, 75% of people can have something going on in their lungs. Now, that doesn't mean that everybody, all those percentages, have ILD. They may not have disease, but you may have some beginnings of some scar tissue or some tiny extra little lines in there, something that we as a lung community are starting to recognize as interstitial lung. We call it an abnormality. Just because it's there, it doesn't mean you're symptomatic. It doesn't mean that it's necessarily even going to progress, but there's something there. And so what do we do to detect those changes early on? So the first thing that we should all be doing when you visit any of your doctors is listening to your lungs, right? So when your doctors are listening to your lungs, and this should happen for all of you guys, is make sure that your doctors are listening to your lungs at every clinic visit. Primary care doctors can pick this up. I've had really the best primary care doctors send me patients very, very early on in the course of the development of interstitial lung problems because they heard crackles. So those crackles that your doctor might hear when listening to your lungs, you take your deep breath in, and then you think maybe it sounds a little bit like Velcro. If you have any Velcro kind of opening and closing, that's really what the lung crackles sound like in early stages of scarring in the lungs, okay? And so listening for that is probably the first screening test. But for all of you guys, aside from doing that, we really want to detect this early. So getting pulmonary function testing is very important as well. Pulmonary function testing is what this guy's doing. Up here, you see he's not making a phone call. It's not a phone booth, right? Pretty soon, the kids aren't going to get that joke anymore, and right, so it's going to be all obsolete. But this guy is sitting in what's called a body box, and it really is just a glass phone booth is how I describe it. And he's doing a maneuver. You can see, I think the door's open on this picture, and he's got something in his hand, and he's blowing into a tube. And the person sitting next to him is a respiratory therapist. Respiratory therapists are huge in a pulmonary clinic, as you can imagine, but they're expert at getting people to do the right maneuvers in the right way in the right sequence to give us all the information we need to tell you about what's going on with your lungs. So the first part of this test, sometimes we just do it as a standalone, is called spirometry. Spirometry is clothespin your nose, and they yell at you to blow, blow, blow. So all your air out, all your air out. And, as a pulmonologist, one of the rites of passage as a trainee is to get one done on yourself. And what they always say is if you don't almost pass out, you're doing it wrong. So it's a really terrible test. I know people don't like it much. It does make you feel see some stars sometimes. But that's really the proper maneuver many times to get the best test, blow all your air out. So that's a very simple first part of the test, and that tells us a lot of information. It can tell us if the lungs are normal sized, if they're a little bit smaller than they should be. We can also use that test to track how lung disease progresses if we do know that you have some lung problems. So that's the first part of the test is close your nose and blow. Second part of the test, they close the doors of that phone booth, and then you just do some soft, regular breathing, slow, big, deep breath in, slow, big, deep breath out. And that, along with some fancy physics, allows us to calculate how much air is inside your thorax, inside your chest. And we can see, again, a more precise test. Are the lungs too big? Are they too small? The next part of the test is one that we spent a little bit of time talking about at the very first talk today, this DLCO. DLCO is called a diffusing capacity. We use the diffusing capacity for carbon monoxide is how it was referred to earlier. That's what that CO is. This test can tell us, yes, about pulmonary vascular disease like pulmonary hypertension. It also tells us about scarring in the lungs. Okay. Sometimes when your scarring in your lungs is present, both your lung volumes as well as your DLCO will be down. Not all the time, but most of the time. Whereas in pulmonary vascular disease, you have normal lung volumes, but low DLCO. Okay. So this test, I always tell my patients, this is the pant like a dog test. If you've ever had it done, and what it does, it just it allows the machine to calibrate to your to the absorption of the carbon monoxide in your lungs and how much you're exhaling. Okay, and this test will give us some more information and again help us guide therapy as well. So these tests probably should be done in every patient with scleroderma. Okay, if you have scleroderma and you haven't done this test, talk to your doctor. Okay, it should be done at least once as a screening test. We'll go through an algorithm a little bit later to really talk through that. So again, on the CAT scan, we said up to 90% of people may have some extra lines or some markings in their lungs that indicate some scar tissue formation. Not all of it will progress. Not all of it will cause any significant symptoms or anything like that, but a lot of people do have those abnormal markings along with diagnosis of scleroderma. So different words that we might use to describe this, I've already used a couple of them. Interstitial lung disease, ILD, pulmonary fibrosis. This is not IPF or idiopathic pulmonary fibrosis. So if you go online and you Google pulmonary fibrosis, which you should under no means ever do, that's not the type of thing we're necessarily talking about here, okay? But we can call the disease by a couple different names, and sometimes, when I'm running through clinic and I'm running a little bit behind, I might just say, hey, let's talk about your ILD. And you're like, what's that ILD thing again? Just if we ever say anything you don't understand, you don't know what we're talking about, please tell us to stop and pause, get that answer for you. So this is just a blown up version of this CAT scan that we were just talking about. You can see again those abnormal markings along the edges. This is fibrosis. This is the scar tissue that goes on to cause the lungs to be too small in interstitial lung disease. Okay. When we look at it under a microscope, you remember that big, fluffy, mostly air tissue that we were seeing on the normal lung alveoli, the normal lung tissue. You can see how scarred up it is on these specimens of lungs that were biopsied or sampled. You can see there's really not much air sac left. There's just a lot of scar tissue replacing it. In the bottom picture labeled A here, this is what some people, some of our pathologists call honeycombing under a microscope. That honeycombing, sometimes you can even see that on a radiology report if you've ever had somebody that you know with interstitial lung disease as well. That can show up there as well. That's another marker of scar tissue and fibrosis. So here's this algorithm that I was referring to. So this American Thoracic Society guideline shows that all patients with systemic sclerosis or scleroderma should have PFTs and at least a baseline high-resolution CT scan. I hedge on whether everybody needs a CAT scan to begin with. I would definitely start with the PFT, but then certainly any signs of an abnormality, I think it's worthwhile to get that CAT scan to see what's going on. If it's abnormal, then we should be following those serially, so every 3 to 6 months, get breathing tests, okay? CAT scans probably don't need to be repeated very frequently, maybe once every 2 years or so, if there is something abnormal present. Okay, so this is all designed at trying to get people diagnosed early, because early diagnosis leads to much, much better outcomes. The earlier we can diagnose it, the earlier we can treat with the medications that we'll talk about later. All right, let's see. So there's a lot of different treatments that maybe you've heard of for scleroderma interstitial lung disease. So these are a couple of them. We'll go through each of them. So we have cyclophosphamide is kind of really old school. Mycophenolate or Cellcept we've talked about a couple times today already. Rituximab I've heard uttered today as well. That's an infusion that you might get. Some other ones that we maybe haven't talked as much about, tocilizumab. I know Dr. Richardson was talking about how good that is for inflammatory arthritis. We also use it in scleroderma interstitial lung disease. And then nintedanib is the kind of a different class of medications that's not really an immune suppressing medication like the rest of these, but more an anti-fibrotic or an anti-scar tissue type medication. Okay, all of these go through years and years and years of study before they ever get presented to any of you guys who might need treatment for interstitial lung disease. Okay, before we jump into this next section, I will pause for a second. Any questions about ILD in general, what I'm looking for, what you should be thinking about, what you should be asking your doctors about? Yeah, please.
What about the treatment like IVIG?
So great question. So IVIG is very useful in systemic sclerosis, but hasn't really been studied in the lung disease component of it specifically. You know, a lot of the trials that I'm going to talk a little bit about look at a lot of different components. So they'll look at, a skin thickness score. They'll look at GI symptoms. They'll also look at lung symptoms. And so some of these are better for one part of the disease versus other parts of the disease maybe not as much. Yes? Yeah, of course. So Cellcept, along with a lot of these other medications, are immunosuppressive medications, meaning they suppress your immune system. They do that by inhibiting the kind of growth or the multiplication of immune cells, like T cells. T cells are kind of essential at causing inflammation in your body. They're also essential at helping to fight infection. And so when we inhibit their growth and their replication, that means you have less of an immune system to go and cause damage at your lungs or your skin or wherever have you. And so that that's how it works, but it's also the side effect. Okay, and so as a side effect of all of these immunosuppressive medications, we're much more at risk for infection, much more at risk for other types of things that go along with that your immune system normally protects you from. So really, it's by inhibiting that T cell replication in this case. Great. All right, so let's talk a little bit about clinical trials. So all those medications on that last slide, think about all the effort that went into creating, designing, getting those medications approved by our governmental agency, the FDA, all the patients that maybe contributed information to those clinical trials as well. It's a huge undertaking. So you can think about the way that clinical trials go from the very beginning of the concept, so the very far edge of this, the very first part of this is just that clinical idea, finding the right thing to treat. So these days it's a lot more precision-based. So we're able to target specific inflammatory mediators called IL-6 or things like this. Whereas maybe before we weren't as sophisticated and we were just treating the immune system and giving widely medications known to, just like we said, suppress T cells or suppress a certain component of the immune system. So we understand what we're trying to treat first, and then the next step is getting into this preclinical phase. We'll skip a few of these because they're more for that specifically designed drug. So we get into this preclinical testing. This is where these medications are tested to see, what do they do in mice? Like what do they do in rats or in non-humans? And are they safe? Do they inhibit the proteins that we want them to inhibit? Do they cause the reaction that we want to have happen? And if you keep in mind, if we go through this whole thing, just going from understanding what we want to treat to starting testing in animals, we're already 3 to 5 years into the course of study for these compounds, okay? So from preclinical testing, maybe we see that, yes, the drug looks to be doing what we want it to do. First step after that is phase 1, okay? So phase 1 trials are these tiny trials that we'll get into these different phases on the next slide, but these tiny trials that most of them are really just aimed at seeing if drugs are safe in normal, healthy patients. not even patients, normal healthy subjects, right? These folks don't even necessarily have scleroderma or any of the diseases we're looking to treat. This takes another year and a half before moving to a phase 2 study, which is a bit bigger. More patients need to be recruited. These trials tend to last about 2 to 3 years or so to recruit people, follow up for an extended period of time, usually at least a few months to probably a year for a lot of our drugs these days, before they get published. If they work, if those drugs are doing what we want them to do, we move on to phase 3 testing. And again, this takes even longer because now we don't have to recruit just a couple patients. We have to recruit hundreds of patients. These drugs take at least these trials take at least another couple years before they're ready for prime time, right? Before we know their results. And then finally, the drug gets approved on the back end, and we have to monitor things after the drug's on the market to make sure that they're safe and effective. So we'll look at it at slightly, and you can see the timeline here is decades long, right? So this is a not a small process that every step of the way has to be a very successful step before we move on to the next one. When we talk about the way that we conceptualize different phases of trial, so again, alluded to this on the last slide. Phase 1 is really just focusing on safety, okay? Trying to find the right dose as well. So if you enroll in a phase 1 trial, you might be in a group that gets a very low dose of a drug that we think might be effective, and that person that enrolls the next day behind you may get a different dose of that drug. After that, a different dose of the drug still. And it's really trying to find which dose is tolerable before it starts causing any side effects. And again, this is usually healthy volunteers that we're enrolling into these phase 1 trials. Phase 2 trials, we start to get more patients involved. We're actually looking a little bit at the effectiveness here, but we also want to see, are there any significant side effects of the medications? This is where a lot of our hope in the world of interstitial lung disease gets started. So, if you see news releases about interstitial lung disease, this new trial just came out and it's looking like this drug might be effective. Usually that's a phase 2 trial that is showing some efficacy. We're seeing that there's some improvement in lung function or stabilization of lung function and minimal side effects. But we really need to move then forward to the phase 3 trial that's going to include multiple hundreds of patients that will then enroll patients over the course of years. And then over those years, we'll finally get the end result. Okay? And this will tell us if the new treatment is better than anything that we've done before. We'll look at a couple of the trials that got the drugs that we use today approved to see what type of a phase 3 trial this might be. Phase 4 trial, this is usually a post-marketing. So after the drug's already released, monitoring it in thousands of people that get put on the drug that we just watch to see how any mild or very rare side effects, if they do develop, what happens then. So this is when you hear, well, this is a phase 2 trial that we're talking to you about enrolling in today. When you come to my clinic, that's one of the things that we are always trying to do is to say, are you interested in participating in these? Because these will lead to the next big developments in drug identification and treatment for scleroderma ILD. So when you visit your doctors, it's always a fair game question to say, are there any clinical trials for my condition? I know that there's, this medicine that I may or may not already be taking, but what else is there? What's the next thing? Is there, I have patients ask me all the time, is there anything new? Okay, is there a cure now? Not yet, but we're still working on trying to find the next big thing. So if you are, number one, I would kind of emphasize that you should already be on the best therapy possible. I would not enroll you in a clinical trial and withhold already approved therapy. I want you on therapy if you can tolerate it. Okay, so some people, though, I have a lot of patients who maybe we've tried to go on mycophenolate or tried to use rituximab, and they can't tolerate the side effects or don't want to deal with the side effects, in which case those folks could also be enrolled in a clinical trial for one of those new possible agents that might control the lung disease. Okay, so number one, make sure you're on approved therapy, and then think about clinical trials. Sometimes then you're lucky enough, and especially in scleroderma interstitial lung disease, we have multiple trials available that you might be able to enroll in. Okay, so when you're thinking about, okay, I might want to do a trial, what do I need to be thinking about? So you want to think about what's the duration of that trial. Is it going to be a year-long trial, like one of those big phase 3 trials we talked about? Or is it going to be just a couple weeks that I have to be, maybe going back and forth to the hospital to get checked out, get my medications, get a physical exam, get some blood draws? Some trials, maybe aren't drug trials like this, but maybe are just registry trials. Okay, these registries you can just enroll in, usually with your regular clinic visits. I know some of them you can even enroll in from your couch. The Pulmonary Fibrosis Foundation has a completely online community registry that you can just log on and enroll in if you're diagnosed with interstitial lung disease. So two very different types of trial models between a registry model and a clinical trial looking at new drugs. You probably want to think about what are the risks and benefits of that medication. So like I told you, all these medications have already gone through at least some preliminary study that then, by the time it's a phase 2 or a phase 3 trial, I should be able to tell you what are the risks of going on this medication. What has been shown in the preclinical data, what has been shown in the phase 1 data. What's the possible benefit? Okay, is there a chance this could be the cure? Is there a chance that this will just stabilize things for me? Or is this really aimed at symptoms? Is this going to manage my skin thickness and not really affect my lungs? Knowing what possible benefits you might get from participating in the trial, you should always know that. And then thinking about what's the purpose, okay? Is this a placebo-controlled trial where you're going to be taking the difference between an active medication and a sugar pill? Okay, that's possible. Or is this comparative effectiveness? Do I get to be on mycophenolate versus another medication for scleroderma? That helps identify what trials you might be willing to participate in versus which ones you might be uncomfortable with, and maybe you don't want to participate in those trials. Most of the ones you will be asked to participate in, though, will probably be those phase 2 or phase 3 trials. Okay, so like I said, those phase 2 that are kind of, we've looked at the drug in people before, but not specifically looking for effectiveness, versus phase 3, where the phase 2 trials were good and everything looked good. Now we need to enroll a whole lot more patients in those trials. Okay, so phase 2 or phase 3 are the most likely. You may participate in a phase 4 if you've been on a trial and your treatment has been shown to be effective. You may be on an aftermarket open label extension study. I don't know if we have internet set up here, but I do have a hyperlink to pulmonaryfibrosis.org here. I don't think it's gonna, here it's starting to, I'm on a different screen. So yeah, here we go. So I always show my patients this website. If you're interested in learning more about interstitial lung disease or have a diagnosis of interstitial lung disease and you're interested in clinical trials, sure, talk to me, talk to our Northwestern faculty here. But you can also go over here to this pulmonaryfibrosis.org website. It's got a lot of great information on here. But you can also go to Clinical Trial Finder. Let's see if I can find where it is. Yeah, so go into you can click on this clinical trials button and then fill out a survey here that will ask you different questions and will match you to available clinical trials in your area. So if you're thinking, I don't really know what's out there, maybe I go to a medical center where they don't often ask me about clinical trials, there are ways to get involved with this type of stuff on your own as well. So I'm going to minimize this. All right, so there's different ways to find ways to participate in this. All right, I'll get back to my slide. All right, so in a trial, at every medical center that you're going to possibly enroll in, there's going to be a main person called the principal investigator. Okay, at Northwestern, it might be myself, it might be Dr. Damati, it might be Dr. Esposito, Dr. Tomich. Each of us kind of sponsors this trial, this one trial that might be at our center, and we have certain roles and obligations that we have to fulfill when we do that. Okay, so as a principal investigator, I am primarily responsible to make sure the trial runs smoothly, that it's run safely, and that anything that pops up that might be going on, some adverse outcomes, some side effect, something like that, I report it back to the sponsor. Okay, we need to make sure that they know of everything that's going on with our patients while they're enrolled in the clinical trial. Okay, your responsibility, if you choose to enroll in a clinical trial, is just to be interested, to be dedicated, to be honest and tell us how you're feeling, and then just to be you. We want to know what real world life is like on these clinical trials. If you're taking a new medication and it's giving you an upset stomach, we want to know about that. Okay, even if it sounds like a small deal, that's an important piece of information that we want to have. If you're taking a medication in a clinical trial and it's giving you lightheadedness or dizziness, certainly yes, we want to know about that for sure, and we'll report that back. That'll then lead us to talk to you about it. Are you safe? Are you able to tolerate the medication? Do we feel like we need to stop the medication? And then give you some honest feedback about what's going on, okay? So what does a clinical trial look like from a kind of 20,000-foot view? So first of all, we have contacts across the medical industry and the pharmaceutical industry, and we get contacted. We're a big interstitial lung disease and scleroderma center. Would you guys be interested in enrolling patients into our new clinical trial? Here's our data. Here's our phase 1 data. Maybe here's our phase 2 data. Here's our preclinical data. And then as a principal investigator, I get to choose, do I think this is a reasonable trial? Do I think this is safe for my patients? Once we kind of assume that that's appropriate, we get it approved by the institution. This is a long process sometimes, but once it gets approved, then we start recruitment. Okay, and so this is when you come to clinic with me. You might see one of my colleagues over here come in the room after you, or after I'm done talking to you about your medical stuff going on. And then what they'll talk to you about is, okay, well, we've got some clinical trials that you might qualify for. Are you interested? Okay, and this is where you need to think about what are the risks, what are the benefits. Do I want to participate in clinical trials at all? Do I go down to Florida in the winter and I'm not going to be around for the next 6 months? These are all things to think about at that point. Hopefully, at some point, maybe enrolling in a clinical trial works for you. Okay, so then you get consented. So you get this, what's called an informed consent. Informed consent is basically just this kind of packet of papers that's written so that you can understand what you're getting yourself into at that point, right? So an informed consent is just making sure that you know what's going on here, that we're not sure this is going to work. We're not sure this medicine is going to be the best thing since sliced bread, right? But we're going to learn about the medication over the course of this. These are the possible side effects. This is how frequently we want to see you. And then you'll have a copy of that for your records, too, so you can refer back to it. At that point, sometimes we'll be doing some screening as well to make sure that you qualify, you hit all the inclusion and exclusion criteria. Maybe you have COPD in addition to your interstitial lung disease or emphysema. Well, that may disqualify you from some of these trials, and so we wouldn't necessarily enroll you in those trials. Then everything goes well, you get enrolled. Okay, you get enrolled and you get randomized sometimes in a randomized trial. You'll get a 50% chance to get this medication or a 50% chance to get that medication. Okay, one of them might be a placebo, one of them might be the active drug. It might be two different drugs that we're comparing with each other. Okay, then you'll come back for visits, right? So, we want to see you. We want to do that exam. We want to probably do some blood work. We want to talk about side effects that you might be having. These initial and follow-up visits. Eventually, the trial will conclude at the end of whatever time that we've decided that we want to follow you for. So at the end of 4 weeks, 16 weeks, a year, something like that. And then at the end of this, at the very end of it, you'll know, okay, what was I on? Was I on a placebo or was I on the real drug? And did it work? Did the clinical trial make a difference? In which case, if it did make a difference, you'll likely be offered the possibility for that phase 4 open label extension trial, where you can stay on the medication, or if you were on the placebo, switch to the medication. Okay, so this is kind of a 20,000-foot view, like I said, of what a clinical trial kind of looks like. I don't know, have any of you guys participated in any clinical trials before? A couple people? Does any of this ring a bell a little bit? Yeah, it's kind of a slog sometimes, right? It's a lot of work, but it's really important work and really, really crucial for the future of patients that come after you. And hopefully, by enrolling in the trial, we do make some benefit for your life as well. So I'll pause there. Any questions about clinical trial design, the different phases of trials? Anybody want to share any stories about when they participated in a clinical trial? Yeah, dedicated, yeah.
Able to
Yeah.
So you gotta get back. I got patients who have to be diabetes for this first, maybe for 6 months, whatever.
Exactly. Yep, and I know we were talking earlier. So sometimes that drug doesn't work, and that's it's a risk of being in a clinical trial. But again, we wouldn't have all these other ones that we're going to talk about, all these other medications, if folks didn't volunteer their time. So, all right, I'll keep going because I know you guys probably want to get through and have a little panel discussion here at the end. So, just quickly, I'm not going to focus too much on the science here, but just to give you an idea of kind of the types of clinical trials, how they run, what the results that come out of them are. So the first big trial back in 2006 that looked at medications for scleroderma was called the Scleroderma Lung Study. This looked at a drug called cyclophosphamide and compared it to a placebo, so sugar pill basically. And participants had to have active disease. You'll see common in these types of trials, you'll have to be diagnosed within a certain period of time before the clinical trial starts. You had certain exclusion criteria here as well. These folks that volunteered for this trial were started on this medication, cyclophosphamide, and they followed them for an entire year, 12 months. And the outcome was forced vital capacity. This is that spirometry, close your nose and blow, blow, blow test, okay? At the end of that 12 months, they found about 70% of patients were able to stay in the study. And what they found was that it actually did pretty good. So we'll look at the visual comparison here. So you can see here, these patients that were on cyclophosphamide had a stable lung function versus those that were on placebo had a dropping lung function, okay, or a worsening lung function. And so that was really groundbreaking news that we didn't have anything to treat this disease before this. Sadly, about a year later, because cyclophosphamide has so many side effects, we can't keep everybody on it forever. When we checked on those patients a year later, all of their lung function was back to the way that it had started. And so the search was on for something different, something better. So a Scleroderma Lung Study 2, again, enrolled a lot of patients, about 70 patients in each group, and they compared mycophenolate, that's CellCept medication, okay, to cyclophosphamide again. They did mycophenolate for 2 years and cyclophosphamide for 1 year, so these folks were enrolled for 2 years of a clinical trial, okay, so a long, long trial. And what they found was that both groups, the mycophenolate group and the cyclophosphamide group, actually had improvements of their lung function over time. So this has led us to think that CellCept or mycophenolate is a good drug. It's less toxic than the cyclophosphamide was, and it showed improvement in lung function at the end of 2 years, okay? Not pictured here is they had a lot less side effects on the mycophenolate group. Another drug that we talked about, rituximab, again, only enrolled 56 people. This is a recent randomized clinical trial from 2021 that showed an improved skin score as well as forced vital capacity improvement. Okay, you can see those improvements over here. So again, looking only 24 weeks on this trial, so we're getting that number down from 52 weeks to even 2 years down to about 6 months in this case. One of the other trials that was just completed back in 2019 was looking at this medication that I talked about called nintedanib or OFEV. Nintedanib is an anti-fibrotic medication, so it helps to prevent that fibrosis that develops over time. Again, they looked at change in lung function over time, and over 500 patients were enrolled for a year in this clinical trial. Okay, about half of them were already on CellCept or mycophenolate. Okay, and these folks actually did better on OFEV than the placebo folks and were able to maintain their lung function longer than in placebo. Okay, so this is a big important trial that came out a couple years ago. Keep moving through. Scleroderma Lung Study 3 was published recently in 2021. Unfortunately, it was published right in the middle of COVID, and they actually had to cancel the trial a little bit early. Their results they presented here were based on extrapolations from the data that they showed. This is another antifibrotic that was compared to CellCept called pirfenidone. And you can see the pirfenidone plus mycophenolate groups had a extrapolated higher lung volume than they did at their baseline. So again, kind of more drugs at our disposal. This most recent medication, tocilizumab or Actemra, we referred to a couple times today. This is a drug that we talked about can be useful in inflammatory arthritis, but it is also useful in scleroderma-related interstitial lung disease. You can see here that 200 plus patients were enrolled in this clinical trial. They were really looking to see if it helped skin scores, but it didn't really help with skin thickening, but it turns out it did help with lung function. So we have another medication at our disposal that, again, think of all the thousands of patients now that have just blown through in the last 5 minutes that have kind of volunteered their time and energy to enroll in these clinical trials that then have gotten drugs to market to treat interstitial lung disease. Okay. This is the extension trial. So we talked about those phase 4 trials. This is an example of an open label extension where patients who were on placebo were able to go on to active study drug, and that active drug was able to stabilize their lung function as well. All right, so the purpose wasn't necessarily to give you all the details on all of those treatments, and I do want to leave enough time for our group to come up. So I'm going to invite our colleagues from our clinical trials team up, and I'll open the floor for questions while they're coming up here. Yes, in the back.
I have 2 questions. I thought you were kidding. I'm like, what happened? My first question is probably easier. The handheld breathing machine with the thing with the low air intake, or like the sleep machine, have you seen numbers-wise those help improve lung function?
So one question for you. Are you talking about the ones you get when you're in the hospital, the plastic ones that you inhale into? The one you blow into, so to measure the amount of air you're blowing? I haven't seen them help, but they are very useful at monitoring disease. A lot of people often will end up after a hospitalization with those, plastic blue things as well that you inhale. And again, not shown to help, but a lot of my patients have come back and told me, yeah, you said it doesn't help, but I do it every day and I swear by it. And really it seems to make a difference. And so I always tell folks, if you find something that helps, if you feel like even the one you're talking about, if you find that helps, go for it. I don't have a clinical trial like we were just talking about, but if it helps you, then that's the most important thing.
Second question, I didn't see you touch on this topic, but fluids in the lungs. What does that, what's the cause from, or what does that look like long term?
Say that one more time, the first part of your question, I missed it.
Lungs in the, fluid in the lungs?
Food in the lungs, yeah. So I know that we talked about that in the last slide. The last presentation. I didn't touch on it much. So obviously we've talked a lot about the GI side effects of scleroderma and how aspiration and acid reflux can sometimes be a big deal when we talk about interstitial lung disease. I think for sure it contributes in some people's disease. It's not the cause of the interstitial lung disease in scleroderma. But it can cause exacerbations and make your disease worse, your lung disease worse if you already have it. And it can certainly, absent interstitial lung disease, it can cause things like pneumonias and recurrent bronchitis and infections as well. So, again, raise the head of your bed, use your ramp, do those things to help prevent those types of problems. Great, yeah.
For the fibrosis tumors, there are any exercise that you can do to prevent getting worse?
So to prevent it from getting worse, you mentioned exercise. Everybody should have a regular exercise regimen. I think that's the most important thing you can do for yourself from an interstitial lung disease standpoint. To help, it's not going to gain you lung function, but it's going to help you feel better, be less short of breath. The better in shape you are, all of those things will help.
If you're taking the medicine, the fibrosis is reversible.
So on some of the slides we showed improvement in lung function, okay? So when we talk about interstitial lung disease, and especially when we're talking about an autoimmune disease like this, some disease is more inflammatory, some is more fibrotic and scarring. Inflammatory disease we feel like we can make better, okay? And that's where that mycophenolate data comes from. Fibrotic disease, once the fibrosis is there, it's hard to reverse it. So our main goal when we see fibrosis is to stabilize disease and to keep it as stable as possible for as many years as possible. All right, we've got some of our experts up here in clinical trials enrollment and more expert at the Northwestern system as well than I am. I don't know if you guys want to talk a little bit first about kind of what you run into in clinic. What are some common questions you get when you're talking to patients about clinical trials?
Hi, everyone. Thanks for making it out this afternoon. My name's Aaron. I'm a research coordinator with the team. Dr. Bemiss kind of touched on this a little bit, but definitely as far as time commitment is something that almost everyone I speak with talks about. So for a clinical trial where you're taking a medication, it is true you may have to come in once a month. I have a trial for a condition called idiopathic pulmonary fibrosis, which is a type of lung scarring. And with that trial, people are coming in for the first few visits, maybe once a month, but then it becomes less and less frequent, once every 2 months, once every 3 months. But with that being said, the patients still have to take the medication every day. So we're always very grateful to patients who are part of clinical trials. They're all completely voluntary. So if it ends up not being for you, that's totally fine as well. But really, it's the patients who take on the brunt of the work with these clinical trials, and we are really there just to kind of guide the process. So visits is definitely something. Side effects of medication is something people ask about as well. Those are always listed in our informed consent forms. Always something really important to know. And then also length of visits is something people ask about as well, and those can vary. In my experience, for the clinical trials, maybe from 1 hour to longer days may go up to 6-7 hours, but we try to let you know well ahead of time what those are going to look like.
Hi, my name is Malek. I'm also a research coordinator at Northwestern, and I think what Aaron said pretty much summed it up. I would say that most patients, when they hear about clinical trials, the first thing that comes to mind is, what can happen to me? And so I think it's very important to have that conversation that there could be benefits, there could not help you, or we could discover something where we would need to stop you from taking the medication. So I think just being open and discussing those things up front is usually the first thing we like to do with patients.
Yeah, I agree with pretty much everything that they said. I'm Kathleen. I've been doing research in scleroderma for about 9 years on the rheumatology side, but we still get to work a lot with the pulmonary folks. I think one of the big things in trials for patients that I've encountered is asking a lot of questions about their other medications that they're taking, including supplements and different type of alternative therapies that they might be doing. I get a lot of questions about that. Is this okay? Is this not okay? Can I switch this? And I think one of the biggest things when you're in a trial is keeping that open communication with the coordinator and the physician and really asking those questions. It's actually really important because for some of the trials there are certain things you can't do and can't take and medications that are unsafe for you to be on while you're in the trial. So I think that's a big thing, is being willing to be in pretty frequent communication with the team. So.
Great. What other questions do you guys have? You can be about clinical trials or interstitial lung disease. Yeah, go ahead.
I have a question. This is more of a concerned partner.
Mm-hmm. Sure.
But if she was to go to, and we talk about this some, if there's a new treatment or a possibility of new treatment in clinical trials, my concern is when we go through the informed consent, as you said, you list out all the side effects. Where in the process is that determined? How do you know or identify what the possible side effects are? So I always get concerned, well, what's going to happen?
Yeah, so it's really all that. So between preclinical data and phase 1 trials, if it's a earlier phase trials, I guess if it's a phase 3 trial, and the phase 2 trials will have informed that. It's just looking at what previous patients have experienced when they've taken that medication. Sometimes we can guess based on the way that we know a drug's going to interact with the body. We can guess at what some of those might be even before we get to the phases of clinical trials, the human research. So, for example, if we have a drug that's, an immunosuppressive drug, like we said, we know one of the side effects is going to be an increased risk of infection already. We don't need a clinical trial to tell us that. So we'll know that up front. But otherwise, sometimes we come out with side effects that we weren't otherwise expecting, like, GI side effects or, nosebleeds or something like that. So those we'll have learned mostly through clinical trials prior. Great. Yeah, go ahead.
It seems like most of the clinical trials seem to be geared to people who've been diagnosed for a shorter number of years. Is there any body that looks at people who've done well for a longer period of time?
Yeah, I think so. Since these are a lot of the trials we focused on at the end, there were medication trials because we're trying to cherry pick the right patients that are most likely to do well with a drug. You have a great point, though, that we have a lot to learn from the folks that have done well and maintained things over time. Usually those are the types of things that come out of those registry trials. So registry trials are trials where we don't give you a medicine. We just ask you questions. We ask you to fill out surveys. So, like I said, sometimes there's one on the pulmonary fibrosis website. You can just answer a question from your couch, how you're doing, and tell us about symptoms that you experience. Some of them, we have a scleroderma registry that is I don't know, is that still, that's something we're still active in? You want to talk
Yeah,
about
we
that?
have a scleroderma patient registry at Northwestern, and I think that Stephanie touched on the Conquer registry earlier too, which is within 5 years. But the scleroderma registry at Northwestern is any type of duration. You could have had it for 40 years.
Mm-hmm. And so what we do, as a researcher, what I would do with that information from a registry is I've got all this patient information already just ready for me to look at and compare one thing to another. So maybe I think, I had a lot of cups of coffee today. So maybe I think a cup of coffee every day is going to make a difference in somebody's lung disease outcomes. Okay, and so maybe we asked you a question on that survey: how many cups of coffee do you drink a day? And then we know how your lung disease has been over time. So then I'll go back and I'll ask the data in that registry. Okay, well, what's the correlation here between coffee and lung problems? And so that's how we use that data in registries. Great. Yeah. Next question.
Piggybacking on what you said in your response to
Yeah.
your cherry picking.
Yeah.
Doesn't that kind of bias your results?
It does a little bit. When we're enrolling patients into trials, we want to get a positive result. We want that drug that we're talking to you about to work. So if we take a patient who's had lung disease for 20 years versus the patient who's very recently been diagnosed, those lung diseases are probably very different at that time. So the lung disease in a patient who's recently been diagnosed is probably more active, more likely to get worse over time, versus the patient who has had the same lung function for 20 years and it's not great, but it's not horrible. That drug isn't likely to do much for that patient. And so, in order to enroll as few patients as we can, because it's hard to get patients to participate in trials a lot of times. So we can't enroll 1,000 patients in every trial. So in order to make that number somewhat more feasible, like 70 to 100, we need to pick the people that we think have the most chance of benefiting from that drug. Oftentimes that means it's those folks that have the shorter duration or more active disease.
And the other question was, if you're in a phase 3 trial and it's helping the patient, and then you have to wait that year and a half or whatever it is for a phase, do the patients get to stay on that drug in that time period, or do they have to just go off and wait for it to
You guys want to talk?
Yeah, it depends. Some of the trials offer something called the open label extension. So some patients, they can be on it for a certain amount of time. It depends on the sponsor. It depends on the protocol. That being said, it's not all phase 3 offer that. But that would mean that even if you were on placebo during that blinded period, that once you got to your crossover visit, you'd be able to be on open label. That means that you're on the drug for as long as they keep the study open and or allow you to be in it.
So another hand, Earl? Yeah.
How
Go ahead.
is the clinical trials funded?
What do you guys want to take that?
Yeah, it also depends. So usually, the pharmaceutical company, they come to us with this proposal, and they're the ones that are paying for everything. That's typically how it works. Sometimes there are trials that are funded by smaller foundations. It depends on the study. Yeah.
Mm-hmm. Mm-hmm. Yeah.
Going back to their question, so let's say you find a drug, it's great treatment, you continue on it however long you're able to.
Mm-hmm.
Does
So during the open label period, they actually cover, the patient doesn't have to pay for it at all. So it's not until it would be FDA approved that it would actually go through your insurance and you'd have to pay, whatever's remaining.
Yeah, and I will say for some of the research, it's a little bit harder to get off the ground sometimes because there isn't that backing of the pharmaceutical industry. Sometimes we'll just propose a trial on our own. Sometimes it's a registry-like trial, like we talked about, the coffee and the lung disease. But sometimes it is a trial going forward looking at, maybe we have a trial right now where we're doing bronchoscopies for patients to learn a lot about the types of cells that are in lungs. And so that's not necessarily funded. That's stuff that we're trying to do on our own. Maybe we get a grant from the government even that might fund some of that research for us. So a couple different ways that we can get some of these studies funded besides just pharmaceutical companies too. Yeah.
So many of the studies, they want it within the first 5 years of diagnosis, et cetera, but also, knowing that, but also knowing that it takes many years sometimes to get the diagnosis.
Mm-hmm.
How do you guys, so if you have a formula, or how do you determine, when, somebody may have gotten recent diagnosis, but the reality is, was probably couldn't have been diagnosed years ago.
Yeah. So you'll see something in some of the slides, the first non-Raynaud's, symptom that you've had. So rarely in scleroderma trials do they look at when you've been diagnosed. So they consider your non-Raynaud's date, so your first symptom other than the Raynaud's, that's when your symptoms started. So they usually base the trial inclusion off of that instead of diagnosis.
And some of these, that's mostly for scleroderma studies. For these lung diseases, sometimes our first chance point wouldn't be until you're diagnosed with the lung disease maybe, or until if your lung disease looks to be progressive, then once we diagnose it as progressive, then we can enroll you in a trial. There's a couple different starting points that we might be able to bounce off of, depending on what the clinical trial is looking at. Great. Any other questions? Yes?
To differentiate between like interstitial lung disease and other diseases in the lungs. I mean, once you're diagnosed, are the diagnostic tools available specific enough to allow somebody to determine if they're overlapping or what might be causing?
So interstitial lung disease versus other diseases of the lung like asthma or emphysema or something like that? Or
Or even cancer.
Or cancer, yeah. So we have enough diagnostic ability to tell the difference between those. I told you kind of one of the things that interstitial lung disease does, it makes the lungs look too small. Other diseases like emphysema can make the lungs look too big, and so we can see that very easily on our breathing tests. Things like lung cancers and things like that, there are certain types of lung cancers that might look like interstitial lung disease, but usually we'll have a diagnostic step in there that we didn't talk a lot about today, including getting a bronchoscopy or even a biopsy sometimes if we're uncertain about that diagnosis. Most of these look pretty convincing just based on non-invasive tests, though. We rarely will need to get a biopsy.
And are patients eligible for clinical trials that you would conduct if they have more than one problem?
It depends on the other problem for sure. So I use the example of emphysema and interstitial lung disease. Sometimes that's an exclusion criteria because the ways that we measure the outcomes would be affected by the other lung disease. Things like asthma, though, or that wouldn't necessarily exclude somebody if it's well-controlled asthma otherwise. Many times malignancy or a cancer might be an exclusion criteria. A cancer might be an exclusion criteria as well because obviously that needs to be treated and that should take precedence over enrolling in a clinical trial too. Yeah, no problem, of course. Yes?
So then, for this process, you can figure out whether it's diagnosed with a scleroderma.
Mm-hmm.
As I said, sometimes I think I'm more scleroderma than, so you guys would determine which is more problem or something like that in the trial, or?
Yeah, I don't know if you guys want to talk about that, yeah.
Yeah, it's a good question. A lot of at least on the scleroderma side, a lot of the trials will say, if you have another autoimmune disease that's clinically significant, then you wouldn't be eligible. But I'm not sure on the lupus end of that if it has the same level of strictness. But a lot of, at least our current trials, they do, unfortunately, it does exclude some of our patients, yeah.
And sometimes that would be certainly a clinical interpretation of it too. So we'd probably talk to Dr. Richardson and ourselves and try to think about what do we really think is going on here? Is there a true overlap, or is this just kind of a different manifestation of scleroderma as well? Great. That's our horn. I think we're done. All right.